Good evening, everyone. Uh, Greetings from Bangladesh. Myself, Vivin Frederick. I work as an RTT for United Hospital, Dhaka. I thank the organizers, especially Oncology Club and Knowledge RT, for giving me this opportunity. As the saying goes, well begun is half done. Any endeavor which begins well usually has a successful ending. So today I will be talking about setup, immobilization, and 4D imaging (DIBS) for radiation, breast radiation therapy. The aim of radiation therapy is to deliver high dose of radiation to target while minimizing dose to the surrounding normal tissue. To fulfill this aim, minimizing margins such as ITV and PTV is of utmost importance. This is achieved by improving patient setup and immobilization. Recent advancement in technology has increased the need for effective patient positioning and immobilization. The patient position must be decided considering possible beam arrangements. Breast cancer is one of the most common malignancies found in women. Adjuvant radiation therapy is an integral part of the treatment. The complex geometry of thin chest wall with regional lymph nodes and the respiratory movements leads to a lot of complexities. Though radiation therapy reduces the recurrence of disease, there are certain side effects associated with it, such as skin changes, telangiectasia, fibrosis, fatigue, radiation-induced cardiac toxicity, and ischemic heart disease. Patient counseling is an important part in the treatment of cancer, and it starts with the patient being well informed about the possible outcome of the treatment and the side effects by the treating physician. And prior to simulation, the CT simulation procedure is explained in detail to the patient, and this is done by explaining her about the positioning devices which will be used, and also about contrast media if it is used. Cancer patients usually go through a lot of psychological trauma. The RTT's responsibility is to ensure the patient is comfortable and not very anxious. The patient is advised to continue shoulder exercises. I have to prevent frozen shoulder. I have shown two of the exercises here. One is a shoulder blade stretch exercise, and the other is a shoulder exercise, stretch exercise. A radiation and contrast consent form is given to the patient, and consent is taken prior to the procedure. Patient positioning and immobilization. The patient position must be decided considering the possible beam arrangement. It is important to position the patient in a comfortable yet reproducible manner. There are three common immobilization devices which we use while treating breast patients, uh, them being wingboard, breastboard, and a thermoplastic mask. When I when I say the patient should be positioned in a reproducible manner, it doesn't mean that the patient has to be tied up so that she is not able to move. The common positioning devices are wingboard, breastboard, and the breastboard along with thermoplastic cast. We at our department, we also use wingboard along with the backlock. The breastboard offers inclined plane with multiple inclination angles, variable handrest position, headrest cushion, and a wedge to avoid sliding of the patient. The limitation being a 70 centimeter CT can accommodate only a 10 degree to 15 degree of inclination. This can be solved by you having a large bore CT scanner at the department. Wingboard is a simple breast patient positioning device which allows to abduct the arm above the head and hold in a comfortable position. The pros being it is simple and comfortable and can be used in a medium bore CT scanner with a field of view of 50 centimeter. And the cons being the chest wall slope cannot be flattened. This leads to collimation of the beam. Backlock and use along with the wingboard. Positioning of patient on a wingboard along with backlock stabilizes the arm and thorax and helps in preventing errors, setup errors basically. In single isocentric technique, the junction is usually below the medial end of the clavicle. So here is a classic example of a patient when we used a backlock along with the wingboard, the clavicle and the head of the humerus, we were able to retain in the same position throughout the course of treatment. Whereas when we use a breastboard only, the clavicle moves up and down, and which also aids the movement of humerus. So why this is important is when we are treating level 1 and level 2 axillary nodes, when the arm is moving superiorly or inferiorly, the axilla along with the nodes move up and down. CT simulation. IV contrast is administered to enhance soft tissue and vessels. Appropriate consent and screening is done before administering contrast by the physician. This means that we take into account if the patient is allergic to any medicine uh, or the contrast media itself. Patient should be explained about the possible adverse effect and counter medicine which may be used if required. Post-contrast simulation, patients are asked to wait for a minimum of 20 minutes and are advised to take a lot of fluid during the day. Why contrast? Why do we use it? We use it because it helps in proper delineation of cardiac structure, vessels, and regional lymph nodes. So here we see the administration of contrast helps us to see the chambers of the heart clearly, and also the LADCA, left anterior descending coronary artery. So far, when we plan a breast patient, the usual consideration is given to the uh, mean dose that a heart receives. But then now studies show that the LADCA also needs to be considered because usually the left ventricle and the LADCA comes into the field while we are treating tangents. At our institution, the protocols which we use for device selection is when we have a small patient with a medium breast, usually a wing board is used with or without backlog, and a breastboard is used when the patient is having a huge breast, and this helps in moving the breast inferiorly. Also, if the chest wall is slope is more, we use a wing board, breastboard. Breastboard is along with the thermoplastic cast is used only in the case of a large pendulum breast. And indexing of the device is of importance because it prevents longitudinal motion and also patient rotation. Yeah. Patient positioning. The positioning of patients should remain identical for localization during the simulation and remain the same during the course of treatment. The patient is positioned in supine position on a breastboard with arms abducted above and externally rotated over the head. Prone position are also used at times, but then the reproducibility is not so well. So we usually prepare a supine position. Often a wedge is used to incline the chest wall parallel to treatment couch as it reduces collimation angle. Headrest, elbow, armrest, knee rest, and footboard are used to provide additional stability. The patient is aligned with the help of wall-mounted movable lasers. Documentation of the immobilization devices used. This is a example of this is one of the setup notes which we use for a thorax patient. Here we can see the details about the position of the patient and the indexing at the couch, and also the headrest which we use, and if ankle rest is used, that is also noted down. This has to be done very carefully because the same setup remains during the whole course of treatment. Simulation and marking. The superior border is at the second intercostal space or the head of clavicle. The medial border is placed 1 centimeter away from the midline. This is to take into consideration the intramammary chain. And lateral border is usually kept 1.5 to 2 centimeter beyond this breast tissue, mostly along the mid-axillary line. The inferior border is kept 2 centimeter below the mammary fold. Marking of the breast. Some of the physicians prefer the whole breast alone to be marked without margins, as this helps them to differentiate between the breast tissue and the adipose tissue, whereas other group of oncologists prefer to mark with a 2 centimeter margin, as this helps them to see how much of lung is also included in the field. CT simulation. The CT data is acquired from base of skull to include the neck and inferiorly to include whole of ipsilateral lung and usually 5 centimeter below the breast tissue. CT data of whole breast including critical structures are needed for DVH calculations. Slice thickness of 2 to 3 mm is usually preferred because it helps us to have good quality image and also good quality DRRs for daily matching. During CT simulation, it is always important to keep the patient straight with the help of lasers, and it also can be checked with the help of field of view indicators when we do a topogram. The level of clavicles can also be checked, uh, and usually care should be taken that they are in symmetry so that patient positioning and image matching is easier. Why respiratory gating? The thorax is subject to setup variations related to physiological factors such as breathing and setup factors related to immobilization devices. To compensate for respiratory motion, large margins are usually added to tumor volumes, resulting in radiation-induced morbidity. 4D imaging helps to view volumetric CT images changing over the fourth dimension, which is time, and thereby which helps us to reduce the volume margins. Gated radiation therapy improves the irradiation of tumor sites affected by respiratory motion, such as lung, breast, and liver tumors. Breathing motion can be reduced by abdominal compression, DIBH, or respiratory gating techniques. The use of respiratory gating during CT simulation allows acquisition of anatomical data and irradiation of target volume in a specific breathing phase. Now, DIBH in left breast radiation therapy is usually two systems are used. One is the spirometry-based ABC active breath control system by Electa, and the other is a real-time patient monitoring system. The variant RPM system consists of an infrared camera. The camera is surrounded by infrared lights aimed usually in the same direction as the camera, and a marker box with the reflective dots. The camera detects the movement of the marker box and calculates the position of the thorax. So this is the camera and the marker block, and the camera is usually fitted on the couch. So this is a typical. This shows us what happens when a breath hold is done. DIBH scanning is done. The patient is asked to hold a breath, and usually an upper and lower threshold is set. Pre-simulation coaching for DIBH. Pre-simulation coaching helps to establish a stable and reproducible amplitude during DIBH. Coaching is given for about 10 to 15 minutes. The patient is explained about the procedure, also why it is important that that he should be holding the breath, and how it is effective in preventing cardiac toxicity. This also is explained to the patient, as it leads to proper cooperation from his side. The patient is positioned identical to treatment position, with hands abducted over the head and externally rotated with the breastbone. The marker box, during the simulation, the marker box is placed midway through the umbilicus and the Ziffert process, and it is marked so that it can be retained during the course of treatment. Audio-visual guidance is used. The patient is asked to hold the breath for 20 to 30 seconds. Once a comfortable deep inhalation level is found, lower and upper thresholds are set. The gating windows are usually between 2 mm to 5 mm. If DIBH amplitude is not stable, patients are asked to train at home, and also sometimes they're asked to visit us, and the RTT supervises and coaches the patient. The DIBH pattern is verified before simulation, and once it is stable, CT simulation is done. So here we see what happens when the DIBH is done. During free breathing, the left ventricle of the heart comes into the field. But then when a patient is asked to take a deep breath and hold it, the lung expands, thereby moving the heart inferiorly and away from the field, and also creating a gap between the chest wall. So this helps in reducing cardiac toxicity. In summary, proper and reproducible immobilization during CT simulation is going to be the baseline, and it's need to be repeated for the entire course of treatment. Appropriate selection of immobilization devices and positioning device for a particular patient is mandate for a successful treatment delivery. Documentation and patient counseling also plays a vital role. DIBH enables us to reduce the cardiac toxicity.